Hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech-language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode.
Hi, I want to first say thanks for having me. I really appreciate the opportunity to talk about Laryngomalacia. My name is Penn. I'm a pediatric otolaryngologist. I started out my training in residency, in medical school at the University of Kansas. So I did my training, my medical school residency, all at the University of Kansas. So I'm a Jayhawk. Finished in 2011, and then did a pediatric otolaryngology fellowship in Chicago. And that's where I met my wife. So I finished my pediatric otolaryngology fellowship, in 2012. And my first job actually was at Vanderbilt. So I was at that center, and it was great. And I had wonderful partners there. And then we actually I had met a co-fellow of mine. His best friend was actually a pediatric otolaryngologist, and he was here in Greenville. His name's Dr. Nathan Alexander. So we met via our wives, and we came to Greenville and loved it. And not only because of the wonderful family community, but the medical community is amazing. We're here, and we've been here for about 4 years almost now. So it's been wonderful.
That's awesome. That's so great. My husband and I actually located here 3 years ago now. So I guess I wasn't that far behind you coming to Greenville. Yeah. Awesome. We're so excited to have you here. Just really excited to not just talk about laryngomalacia and how it impacts feeding, but also understand it from the otolaryngologist side. And I think that's really important for us, like when we're moving forward, when we're making referrals, when we're providing treatment, to understand all the different sides that kind of come into play. So just to start out, what is laryngomalacia? For some people, this might be a totally new term. So just kind of start from just what is it?
Right. Well, I always, when we get referrals in and I'm seeing families in the office, honestly, usually it's mom, and mom is there with their little one. And a lot of the time, most of the initial visits are the mom saying, my little one is just really noisy, and we're in line at Walmart and people will look and my child's really noisy, and they'll ask, what's wrong with your child? So we get a lot of referrals. I see a lot of initial patients that are less than 1 year old that are noisy breathers. And moms have actually done a lot of the research. So they may be on a Facebook group or maybe Google researching and say, why is my child noisy? And interestingly, one of the first things that comes up is laryngomalacia. So laryngomalacia is probably one of the most common causes of noisy breathing. And the noisy breathing usually is classified as, or we term it stridor. And so there are different terms to describe noisy breathing. Stridor is the most common, and stridor is usually when you breathe in versus breathing out. So that's one of the first questions to ask families and moms is, okay, is it louder breathing in or breathing out? Because to me, that can tell me right off the bat, is there an obstruction or is there a problem in the upper airway, which is vocal cords, supraglottis? So really, stridor tells me, stridor or the noisiness, whether it's inspiratory or expiratory, tells me, is it above the glottis, right? Is it glottis, supraglottic, or pharynx? So stridor usually is a sound that's right at the glottic level, but it can be in the supraglottic level or below. That's different than something called stertor. And stertor is a sound like a snore. So that's like a nasopharyngeal sound. An example of stridor would be right? Inspiratory stridor, whereas stertor to me can also be inspiratory, but is So different. So most moms and most families that come in will say, we hear this noisy, high-pitched breathing, and it seems to be more with breathing in. Now, laryngomalacia can start as early as day one of life. A lot of families will say, we did great. We started breastfeeding or we started bottle feeding right away in the hospital. We were doing great. And then we got home and all of a sudden my child's noisy now. And a lot of families will say it's noisy and it doesn't seem to bother a child. And that's, to me, that makes me feel a little bit better because if the family has the feeling that, well, things are stable, we're gaining weight, we're doing well, perfect. That's wonderful. We can continue to watch and make sure this is laryngomalacia. But if the family is getting worse and we're getting louder and we're starting to have signs of working harder to breathe, and to me, that's a red flag. But to get back to laryngomalacia and really stridor. So a lot of families will come in and say, my child has stridor and they have the stridor or they have stridor. And okay, stridor is a symptom or a sign. And there's a lot of things that can cause stridor, and laryngomalacia being the number one. But when they come into the office, usually our diagnostic tool is a flexible fiber optic laryngoscopy to assess, hey, yes, this is laryngomalacia or not. And the way I usually describe laryngomalacia to families is to think about your voice box and your larynx is made of cartilage. And one theory is that the cartilage is immature. So I like to use the analogy of, you think about the cartilage in my ear is like old crusty old man ear. So it's really hard and firm. And then with your child, the cartilage of their ear is nice and soft and just beautiful. I let them know that, hey, an older, mature cartilage versus immature cartilage. And when you take a deep breath in, everything opens. And we have a nice linear flow of air through the supraglottis, through the glottis. Whereas if you think about this immature cartilage theory, when I take a deep breath in, instead of things staying open and staying rigid, they're collapsing in. So a lot of times that gives families a little bit more, oh, that makes sense. If I have a more floppy, immature cartilage, when I breathe in, things are going to collapse in a little bit more. And that's when I'm hearing the stridor sound. The other theory behind laryngomalacia is that the neuromuscular tone to the voice box is just off. And it's just a normal process that we all have to go through, and some children have it more than others. And then even a third theory is that we're just born with the tissue surrounding the larynx, so the aryepiglottic folds and the arytenoids are just more redundant, and the aryepiglottic folds are really tight, and it tethers the epiglottis back. So when we take, a nice deep breath in, things collapse and we have prolapse into the glottis, which creates the stridor. So regardless of sort of the theories, I think the big thing that I always counsel patients on is it's this floppiness of the airway that contributes to stridor. And there are a lot of other things that cause stridor, but we need to make sure that, okay, it is laryngomalacia. And once we diagnose this as laryngomalacia, then it's just mild, moderate, or severe, and we decide treatment from there. But it is absolutely the most common cause for stridor. One of the mainstays, we can get into this a little bit later, but most of the children we see, 90% of them outgrow it, usually by the age of 2 years old. Although more recently, there's something known as occult laryngomalacia, where children have it or it persists throughout the first 5 to 6 years. And we usually find it after a child continues to have obstructive sleep apnea after a tonsillectomy, adenoidectomy. So it's more contributing to more of a sleep apnea picture later on in life.
Gotcha. Yeah. That makes sense. Yeah. And I think obviously you talked about one of the main signs is that stridor. And that's what I'll hear parents are like, it's a super high pitch, or it sounds like a whistle when they're breathing sometimes, or they'll notice it not just when they're sleeping, but when they're feeding as well. And that's really big, especially with infants. And that's something that us as SLPs will see is I have a little one that comes in and I'm observing them feed. And I notice after every couple suck, swallow, breathe, suck, swallow, and then you notice that sound that on that inhale where it's high pitched and they're like trying to swallow, trying to breathe, and a lot of that going on. Then we notice the stridor during feedings as well. And then, like you had mentioned, some of that, if you're starting to have those feeding difficulties, is weight gain becoming an issue, then those are reasons that we as SLPs really need to be pushing for that referral further.
Absolutely.
I was going to ask too, something else that I notice that I see a lot of with these infants, and you can probably speak more to this, is I find that reflux happens a lot at the same time. Sometimes maybe I notice that, they don't have as much of the noisy breathing. They might have some of it, but they also tend to have a lot of reflux.
Absolutely. And there's some really good studies that support that as well. I think the incidence in children with laryngomalacia is anywhere between 60 and 90% of children have some degree of reflux. Or I get into discussions with our pediatric GI doctors all the time about reflux. Okay, It's not reflux, it's laryngopharyngeal reflux. So we have the laryngeal issues and the laryngeal concerns about reflux coming into the larynx and affecting the nasopharynx. And they go back and forth on it. And they're a great resource to have, but there has always been interesting debate between otolaryngologists and GI team members. But they're wonderful in that they can add another piece to, well, is this child an acid overproducer? They can add a pH or an impedance probe to help us sort of determine, do we need to have an H2 blocker or do we need to add a PPI? So I do have a lot of patients that also we refer them to GI to help us with a lot of the reflux, but you're exactly right. To get back to laryngomalacia and reflux, I would say the majority of children that have moderate to severe symptoms of laryngomalacia are usually on reflux medication, or usually I recommend reflux medication, because when they get into that moderate range, it's not just acute noisy breathing and we're just happy and gaining weight. When we get to that moderate range, you start to see more signs of work of breathing. And that's one of the things I always talk to my colleagues about, or to moms about. It's, the noisiness. All children are noisy, right? Some to more degree than others, but when that noisiness starts, it's a clue. And when that noisiness starts to get into more work of breathing, that's like, okay. So the things that show me work of breathing: nasal flaring, head bobbing, suprasternal retractions, intercostal retractions, all those things tell me, okay, the child is using more energy and using the calories they're trying to feed to breathe rather than grow. And so, like you were bringing up earlier, the typical things parents will complain about or will notice is, well, they're noisy. They may be noisier on their back more than upright. And oh yeah, when we feed them or breastfeed them, they are squeaky, and they are squeak, 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 squeak. And that suck, swallow, breathe coordination is completely off. And I think about it as, okay, I just tried to get off my Peloton bike and I'm really tired and I'm trying to drink my water and somebody's pinching my nose shut. Of course, they're going to have difficulty with my suck, swallow, breathe as an adult. So as a child, as an infant, a lot of families will say, yeah, with the feeding and after feeding, even for 20 or 30 minutes after feeding, they have stridor because they're just so worked up and they've been working so hard. The other sort of instance where we see a lot more stridor that parents notice is when they're sleeping. So in a sleep dependent state, they notice, hey, we're snoring. And I'm like, okay, is it princess snoring? Or is this like old man? This is grandpa. So most of the families will say, oh, yeah, even though my child is 3 months old, I can hear them on the monitor breathing. And I'm like, oh, let's talk about that. We need to talk about that a little bit more, because that's not a normal thing that we should see in our children. So all of that, like you're saying, there's a vast array of symptoms from mild to moderate to severe. But like you were saying earlier, one of the mainstays of treatment to help with laryngeal sensitivity, laryngeal edema is reflux. Reflux is a whole nother topic in itself.
Whole nother podcast.
Yeah, but one of the really interesting studies that I think is out there related to laryngomalacia is that they have it was like a landmark study where they looked at reflux in children with laryngomalacia, and they had a control group of children that were in the moderate to severe laryngomalacia, and they followed them at 1 month, 3 months, and 6 months. Then they had a separate group that they put on reflux medication, and the first group was on a reflux medication, and they again followed them from 1, 3, and 6 months. None of these children got operated on, but they did something called a feast test, right? So where not only are they assessing swallowing, but they shoot this puff of air to test the laryngeal adductor response. So they want to see laryngeal sensitivity. And so what they notice is that children that had laryngomalacia that were on reflux medication, their thresholds to create an adductor response were a lot lower. And the children that weren't on reflux medication, their laryngeal sensitivity was just so diminished that their thresholds were so high. So those children fell into this, they were penetrating on thinner liquids more often than not. So it was this interesting study that sort of reconfirmed why we put children in that moderate to severe category on reflux medication.
Yeah. No, it definitely makes sense. And I've seen that firsthand. One of the cases I'm going to talk about later is one where that was really evident, where the laryngomalacia was more on the mild side, but the reflux was severe enough that the sensation was very diminished at the pharyngeal level. All right. So now that we've talked about some of those main signs and symptoms, we're making the referral to an otolaryngologist. This is what we're concerned about. What can a family expect? Because I think it's important for us to know this as well, of like, when they go to that appointment, what can they expect? How are they diagnosed? And what does that process look like?
I think what the family should expect when they come to see myself or my partner is that we're part of a team with everybody else. So we're a multidisciplinary team. And yes, we may be a key in helping with the procedural, diagnostic, or surgical aspect of it. But I think one of the things that I try to discuss with my family in the middle or towards the end of the visit is, hey, we're part of a team. And this may include, our speech therapist, our pediatric GI team, our pediatric pulmonary team, our occupational therapy team, all these things. So we're part of a team. And so I want them to feel, because I think that's the hardest thing for families, is feeling like I'm alone and this hasn't been seen before. And we're going to go in, and what's going to happen to my child, to my 1-month-old or my 2-month-old, especially if they're first time mom. So I think that's a thing. And I always love to tell them, like, let us help you. Let us share this worry with you, and we'll get through this together. So I think that's the first thing that I love to impart to families, and is that we're part of a team. But usually when families come in, one of the things that I let them know early in the visit is that we're going to be performing a procedure today. And a lot of times that can be, especially if it's a first-time family, they think procedure and they think, okay, my son just had a circumcision, or my son or daughter just had a frenotomy. And was it like this? And usually what I'll tell them is we do, it's a small scope. It's about 2.7 millimeters, so a little bit bigger than the size of a spaghetti string. It goes into the front part of the nose and assesses anterior, mid, posterior nasopharynx, supraglottic, glottic structures. So it takes usually about 30 to 45 seconds to do. But I think that once I tell them that and walk them through, this is how it goes, I always let them know that I've had it done as well. So I have had it done by medical students who aren't very good at it. And I don't want it done every day, but I know what their child is going to go through. And then also my son, who's 4 now, and he was about 18 months. He had the same procedure, and I was there, and I was the muscle that had to hold, or my wife was the muscle, that had to hold him while he had it. So that this is how we sort of diagnose it. So we perform flexible fiber laryngoscopy, and then once we complete that, usually I record every scope exam that sort of gets uploaded to their medical record. And then we calm down. Okay, if the child needs to feed, that gives me a really good time to hear them feed afterward at the same time as well during the visit. And then we review the exam, and we talk about what normal looks like. And I have this great app that is free, and it's from Cincinnati Children's Hospital. It's called the Pediatric Airway Card. And so I love to use it because for me, it does a lot of the ENT stuff that we do when we do our bronchoscopies, but it also shows from an infant standpoint what a normal infant larynx, glottis, subglottis, distal trachea and carina looks like. And so to me, I think that's the biggest thing, where the family can look at the video and I can hold up my phone and say, this is normal supraglottic glottis, and this is what your child looks like, and this is why it looks swollen. And they're like, oh yeah, that makes sense. That makes sense to me why they're floppy. That makes sense to me. So I think that really solidifies, okay, laryngomalacia, and it makes it a little bit more real, rather than in the old days when we didn't have the opportunity to photo document, and it was just maybe a laryngologist that was putting a scope in the nose and they're taking it out and say, you have laryngomalacia, here's your reflex medication. So I will say there is a lot, probably the physical exam and the procedure part of it is 5% of the visit, and 95% of it is education. And just what do we do if we start getting noisier, and just education on what to look for, what the next steps are. And then usually the family, once they leave, if we have to order studies like a video swallow study or a fees study or a sleep study, those things are done more urgently if we feel like that child needs to be seen sooner, or in a little bit more of a delayed fashion if they're doing well and gaining weight.
Mm-hmm. Yeah. Awesome. No, that's really helpful, because I think sometimes, I can speak from the SLP side, sometimes we're the first person to observe a feeding or something. And so we're the first one to be like, oh, do they do that all the time? Or do you notice that they have that stridor or different things like that? And so I think it's nice when we are able to say, hey, I think a referral to an otolaryngologist is appropriate, to be prepared to say, this is what you can expect in a visit, and this is what's going to go on. I obviously collaborate with you, and so I know the process and all of that with you and Dr. Alexander. But I think for some people, sometimes it is an initial consult and then they come back and do the procedure at a later time. I appreciate the one and done. And I think a lot of families do as well, especially if they're coming in of just, yeah, we're going to check it out and see what's going on. But I think it's important to know what the procedure is, because just as you mentioned, like for families, especially when it's an infant, whether it's their first child or their 6th child, it's scary. And laryngomalacia is airway. And that in and of itself is scary to parents to hear of, what do you mean their airway might be obstructed? Or what do you mean they're having trouble breathing? That's really scary. I think being able to break it down into those simple terms is really important. So not only do they hear that coming from you when they get to the procedure, but they also hear it from us as the SLP first. Hey, here's what you can expect. And this is a small part of it, but it's something that's going to really help us figure out how we can best support you and your child. So
Right.
awesome. All right, let's move into, now we have the diagnosis. What are some of the treatment options? I know you briefly mentioned before, most children do grow out of it by 24 months, but what if it's really severe? What if we're having a lot of difficulties? Or if it is on the more mild side, what are the treatment options and how is that followed?
Yeah. So usually if it's more based on the physical exam, the flexible laryngoscopy and their symptoms, if they're gaining, so a typical mild laryngomalacia would be family comes in, noisy breathing, maybe at night, maybe with feeds, but no signs of increased work of breathing. They're in the 90th percentile, let's say. They take a bottle in a normal volume for their age and a bottle within 15 or less minutes, and they're doing well. And the family's saying, hey, we just want to confirm this. A lot of times it's just, hey, we confirm they have laryngomalacia, which go back to our point of how the family's journey to us, multidisciplinary team, is like just having the diagnosis of, yes, this is laryngomalacia. It's, oh, okay. Yes. Okay. We're ready. So that's really important. So a lot of times if they're in the mild category and they're gaining weight, we see them back maybe in a month, maybe depending on how they're doing. And if family needs more reassurance too, we may see them sooner. And then I'll see them back 3 months after that. And if things are continuing to improve over time, it's, hey, I'm glad you got to see Dr. Penn. I'll be sending. I'm sure you'll be happy not seeing me too. But then there are also some children in that mild category that as they get older, maybe their inspiratory force gets a little bit stronger. And so now initially they were small and their inspiratory force isn't as great as they are when they're 7, 8, 9, 10 months, when they're starting to move and exert themselves. You may notice it more, and then that may uncover more symptoms. But just from a mild standpoint in children that are seeming to progress normally and their symptoms are slowly improving, usually it's just supportive. The children that worry me, that have fallen into this moderate to severe category, are when I first walk into their room, if I see that they are scrawny and they don't have like thick thighs, it's, oh, what's good? First it's, okay, what's going on? Tell me about feeding and the noisiness and work of breathing. But the children that fall into, well, failure to thrive, they're having signs from their speech, from their SLP, of aspiration or tearing or coughing within liquids or just struggling with the suck swallow breathe, those children in my mind automatically fall into a moderate category. Based on if it's a swallowing issue and a suck swallow breathe, then the two studies usually that are our mainstay of assessment are a video swallow study or a FEES. Thankfully, we have a FEES clinic. We have the capability of doing that as an outpatient in our hospital. But there are some centers that don't have FEES, and so they rely on video swallow studies. And I think they're complementary to each other, and they both give great information. One of the things I like to keep in mind, though, is that there's a campaign that's national. It's called Image Gently. So we don't want to give a child a giant dose of radiation for a video swallow study if they were premature, if they've had 20 x-rays before and now they're home, and you're just adding another fluoroscopic study or radiation in this first year of life when they've already had enough for 4 or 5 children. So when that's the case, I try to rely more on FEES to look at that. And so we have our clinic, and that sort of helps me not only look at structure, but function. And also gives me assessment of laryngeal edema, laryngeal sensitivity, pooling of secretions, penetration versus aspiration. So that really, I think, helps us from the swallowing standpoint. The other things that worry me in that a moderate to severe category are signs of obstructive sleep apnea. So we go back to, hey, my 2-year-old snores like Uncle Jimmy. I don't have an Uncle Jimmy, but those children, when they're having that work of breathing or they're snoring or there's apneas, that to me is not normal. And one other study we can get is called a sleep study. So that actually, and probably in the last 8 to 10 years or so, has been able to be utilized in more children under 1 year old, and even in premature and our NICU babies, we're able to get sleep studies as well. So that can tell us, okay, maybe they may be swallowing or getting by from a swallowing standpoint, but their laryngomalacia may be affecting more of the sleep disorder breathing symptoms, or they have obstructive sleep apnea at night, and that may push us to intervene more from a surgical standpoint or not. But we had talked about reflux earlier. I think the children that usually fall into moderate to severe laryngomalacia and they have physical signs of laryngopharyngeal reflux on their exam or laryngeal edema on their exam, usually I will start them on a reflux medication. A safe reflux medication on somebody under 1 year old is Pepcid. So that's a great medication. You can be once or twice daily dosing. So famotidine, that usually is the mainstay. Interestingly, PPI is also can be used in children. So one of the more common ones we use in the GI world and in the PCNT world is omeprazole. So from an FDA standpoint, it interestingly is not, there's no significant recommendation for children under 1 year old, although a lot of our patients have them on it. So if we are not getting good control with famotidine, a lot of times we'll loop in the GI team to sort of help us manage that and make sure we wean off it appropriately at the appropriate age. Besides the reflux standpoint, the other thing from a fee standpoint or from a video swallow study standpoint, we find is, changing the consistency of feeding, right? So if, let's say, the laryngomalacia isn't affecting any significant sleep issues, we're not having apnea, but it's just a feeding issue. And a lot of times with reflux medication and changing consistency to half nectar, nectar thickener position, a lot of times that can get a lot of children by this early 6-month period and sort of move them along.
Definitely. And I think that's sometimes where our role comes into. Can we just change the nipple size? Can we work on pacing? Can we change positioning and work from that point too, based on what the results are showing us? And then, so I guess, my follow-up question to that now, which I'm sure is the direction you're about to go in, is, so if we do have some of that obstructive sleep side, what are the options from there?
So usually from the obstructive sleep standpoint, it depends on where they fall on our sleep apnea score. So there's a same, just like laryngomalacia, there's a mild, moderate, or severe. When children, absolutely, when they fall into the severe category, then, my discussion with the family is, well, we need to start thinking about surgical options, because the other option besides surgery, and I always bring up a non-surgical option first, because nobody wants their child to have surgery. Absolutely not. And as a dad first of 2 boys who have had surgery, it was necessary for them, but nobody wants their child to undergo anesthesia. So I always try to start with, there are options. We have a pediatric sleep medicine team who are amazing. And one of the options is positive pressure, and positive pressure falls into the category of CPAP. So CPAP, traditionally what people think of as, okay, I'm going to use Uncle Jimmy. I don't have Uncle Jimmy. But it's a mask that goes over your nose and mouth, and it pushes air in. So it pushes air in and it keeps a column of air in your nasopharynx, oral cavity, glottis, and trachea, and it stents your airway open. Now, before I had children, I would have honestly thought like that absolutely is a reasonable thing. I'll refer you to peds sleep medicine. So now that I have a 3 and a 4 year old, so now that I have children, there's no way in our house. I don't think either of my sons at less than 1 or even now would have been able to do that. We're able to wear a CPAP. I just don't think it's a feasible thing. I do let families know it is not. There are some children, to stay on the medical route, there are some children that have significant enough reflux that the reflux actually contributes to sleep apnea. So I've had children that have had mild laryngomalacia and are having these horrible reflux events at night. And it's causing upper airway resistance. It's causing these apneas and pauses. So that's another way the PGI team can really help us out by determining what degree of that. I've had several children that have had mild laryngomalacia and severe milk protein allergy, or EOE. And once we treat that, they've nearly cut their sleep apnea score from severe to nearly mild. So without surgery. So I think it is important from a multidisciplinary standpoint to make sure you're keeping the medical evaluation or doing as much as thorough as you can from the medical standpoint prior to discussing. But the surgical option for children with laryngomalacia is, when you discuss with families, it's really, you're talking about, okay, this is my, like you said, 1st or 6th born, but this is my child and they're getting anesthesia. They've never had anesthesia before. They're going to have a surgery. And a lot of times I think when people think about surgery, it's okay, there's going to be an incision somewhere. And my discussion with them includes that this is all done endoscopically. The procedure is called a supraglottoplasty, and it involves using a microscope and a laryngoscope to assess the airway, to look at the rest of the airway. And then whether we use laser or whether we use micro scissors or micro instruments, we're making incisions to open up the airway. The other interesting thing that I always tell families is that not only are we focusing on the laryngomalacia, like, yes, the laryngomalacia is why we're here. It's why we're talking about surgery or medical treatment, but 20% of children can have other concomitant or synchronous airway lesions at the same time. So a big one can be subglottic stenosis, which is an narrowing right below the voice box. We see a lot of tracheomalacia that's also associated with laryngomalacia as well, or bronchomalacia. So it's really important that not only are we assessing just a laryngomalacia and a degree of obstruction while they're sleeping, but also the entire airway, again, from the nose down to the carina, where the carina branches to the left and right bronchus. It's so we're not missing anything. The other thing I will sort of mention too, and we talked about stertor, is that I've had some children that they have severe obstructive sleep apnea, they have moderate to severe laryngomalacia, they have a positive sleep study, we've treated the reflux, we're headed to surgery. And during every procedure, we always, again, look in both sides of the nasal cavity, because sometimes there can be issues with the nasal cavity could be more narrow. There's something called piriform aperture stenosis, which is the front part of your nose just didn't develop as well. So both or one side of your nasal cavities may be more narrow than the other. There's something called choanal atresia. We can have that unilateral or bilateral. And children up until 6 months of age are nasal breathers. So if one side of their nasal cavity is obstructed, you absolutely can have obstructive sleep apnea, and you can have this concomitant airway lesion with laryngomalacia. So just important that when we talk with families, we say we are assessing the entire airway, and we're doing it in a sleep-dependent state to make sure we're not missing anything and make sure there's nothing else we're going to have to intervene on or watch as we get older.
Yeah. And I think that's such an important point too, because airway, like in the feeding world, airway, we always talk about like airway trumps all. So if we do not have the airway managed from the entire point of view, then we're not going to have a lot of success with our feeding. And I'll even see that in some kiddos that are older, where they are just like chronic mouth breathers. And it turns out they had 90% of their airway closed off because of their adenoids. And so you get that fixed. And then it's,
Right.
now we can focus on chewing because we can close our mouth for more than a second because we breathe through our nose now. And so
absolutely,
seeing it in that way, in addition to, and so I think that's where also taking into consideration, there's so many other things that can impact airway. So while laryngomalacia is one, it's where it's really important to think about what else could potentially be going on. And so if you are hearing more of the stertor than the stridor, what could maybe be going on in the nasal cavity that's going to point us in that direction? Yeah, no, that's super, super helpful. And I think from the SLP standpoint for feeding and stuff, we just have to know what severity level is it at? What are the concerns coming from the otolaryngologist? Because feeding is just one part of the puzzle, and sleep is a really important side of it. And we also have to think about that when treatment is moving forward, and being aware of what steps are going to be taken so that we also know how to then make modifications to help along the way.
Absolutely.
So anything else to add before we talk through a couple cases of things that have gone on?
Yeah. So another sort of topic to discuss is most of the time, if let's say we're doing a supraglottoplasty for obstructive sleep apnea for a child, majority of the time, like upwards of 90% of the time, the children will be significantly better afterwards. But interestingly, they found that if you do another sleep study later on, their number won't go absolutely to normal. So there is some degree of, even after supraglottoplasty, some children that still will remain noisy, but to me, it's okay. Is their work of breathing better? Are they more efficient feeders? Or is their airway maintained so that they're not going to have any, significant postural issues or headache or neuromuscular issues later on? So that's, some children need revision surgery, but those children usually fall into, there's some underlying GI or underlying reflux issues that may not be, we didn't notice or didn't diagnose up front. Or the other sort of branches, well, there may be an underlying neuromuscular issue that we still need to focus on. One other thing to discuss, like medical therapy and a complete looking at the child as a whole, is there are the minority of cases. So the majority of cases of laryngomalacia are, there's no family history of it. This is just, they've had 6 children and this is the 7th and they just have it. And so the majority of the cases, again, mom, dad, grandparents, nobody has this finding in their family. But there are some families that we run into that the family say, oh yeah, her sister had laryngomalacia. And this is how we knew that this one has, or great Uncle Jimmy had some noisy breathing and maybe he had asthma so there are some things that always make me wonder, is there a familial thing going on that we need to look into that more? Or is there a neuromuscular underlying central nervous system issue? One thing or one diagnosis that I have absolutely seen is something called a Chiari malformation, where the cerebellum sort of sits a little bit lower. And so I talked to the family as well, that the cranial nerves get squished as they're sitting in the vertebral column. And so all those important nerves, like the vagus and all these things that come out, affect laryngeal tone, affect your tone while you're sleeping. It affects your laryngeal sensitivity. So there absolutely are some children that have an underlying Chiari malformation, and the way that we diagnose that is an MRI. But I've had some children that once, if we were worried about that and we diagnose it, We refer them to a pediatric neurologist. And if that gets corrected or whatever, whether it's surgical or not, their sleep studies and their swallow studies get significantly better without surgery. So from a neuromuscular standpoint and a central nervous system standpoint, it's always something again, I'm part of a team. So it's my job to make sure that I communicate with the speech therapist that if they're seeing hypotonia issues or other postural things that aren't supporting, we just have a fixed airway problem and nothing else, and that we communicate and make sure, hey, we get an MRI, we get those things. So.
Yeah, for sure. And that just goes, into finding that like underlying reason why, because it's really hard to treat something if we don't figure out the why behind it. I say that all the time with feeding. I'm like, if I don't know why they're having the difficulties, how am I going to move forward with treatment? There's things I can do, but we're going to reach a point where nothing else is going to be able to happen. So like you said, you might take, okay, here's our first step. If nothing changes, if things get worse, if things don't get better, or then you can say, all right, what is our next step from here, and be able to move forward from there.
I think the last thing that always worries me about any of these children after surgery is their swallowing function. My worry, especially if they already have a pre-operative swallow study where they're aspirating significantly, my worry is that, okay, we're doing a procedure to open up the airway, and potentially, and one of the risks of surgery is that their swallowing could be worse afterwards. So after surgery, usually we have one of our inpatient speech therapists come by and do a bedside swallow to make sure they're still swallowing. Hopefully their swallowing is improved, or at least baseline. But one of the things I always tell families, and one of the risks of it is as well, we may have to have, when this is a rare instance, we may have to not have anything by mouth, NPO for a little bit, if we're still healing and we're still trying to figure out our larynx. And so that's the other thing, and why not everybody does this, but a lot of people, me included, will do a preoperative video swallow study or a fee study to assess baseline prior to surgical intervention.
Yeah. So. To figure out then if something is going on after, where it is. I think that's important too, because sometimes if we don't have, and I talk to families about this, I know we've talked about this before, is if there aren't any signs showing me that we're having difficulty with swallowing, I'm not going to put a child through a swallow study. But I think sometimes doing that beforehand, then doing it after, you have a comparison. So like their normal might not look what we would consider normal, but if they're not having any of those other difficulties, it at least gives you that baseline to compare to of, oh, this was their normal. And okay, because we all have a range of normal. I'm sure my swallow probably doesn't look normal if I ever had it looked at, but I am functioning and normal and not getting sick and that sort of thing. Yeah, that's a great point. Okay, I have one case I want to talk about with laryngomalacia. So do you want to go first? Do you want me to go first?
Why don't you go first?
Okay, I'll go first. So I'm going to talk about a kiddo who had come to me first, and then I was making the referral. So I had this little one come. He's 10 months old. Had previously been seen by a lactation consultant when he was like 9 months old. And at the time, it was a weird story because he wasn't actually breastfeeding at all. He was only bottle feeding at this time and starting solids. And mom was just like, we're having trouble with solids. We're not doing great with the bottle. She just said he was like a super messy feeder. Anything that had more than smooth consistency, he would just like gag or spit out. He would gag to the point he'd throw up sometimes. He didn't want to swallow anything. And then she had also told me that before they had come to see me, she was like, oh, when we saw the lactation consultant, they said he had a tongue tie. And so she just like immediately referred for release of that. They had the release, and mom was like, had gone on Google and all the things and was like fully convinced that's what was going on. Like, he snores, he has feeding difficulties. It must be the tongue tie. And so mom had actually come to me because thankfully the pediatrician they saw, they were like, I still think you should go see a speech therapist. Like, I still think you should go. Mom was like, whatever, I'll come see you. The lactation consultant had told mom, now that it's released, it'll just take him a little bit. He'll get used to it and you'll be good to go. So mom comes to me, and it's about 2 weeks post when he had the release. And she's like, nothing's really changed. He had the release. She's like, I feel like he stopped snoring for a day, but then it just came right back. He's still having difficulty on the bottle. And then all those feeding issues that I had mentioned before. And so I probed mom further. I'm like, what's the snoring? Tell me about this. It was very positional. If we were laid back all the way, it was a lot noisier. When he was taking the bottle, it was a lot more of the whistle going on. And so then there was just like a ton of spillage happening. And she had mentioned he was really a totally fine feeder initially, but I just feel like things started to get a little bit worse around like 6-7 months. And so she attributed that to starting solid foods, but also his bottles weren't really going well. I had asked her about, have you tried a straw cup or anything? He hadn't really. And so we actually tried one during the evaluation. He did okay, but he was coughing. And I had probed her about that. Oh, does that happen? And she said, oh yeah, it happens on the bottle too. And I probed, has he ever been sick? And he'd actually been hospitalized for bronchiolitis before. And he's had ongoing just like respiratory infections off and on. But she's attributing it to he's a toddler. Like we just get sick. And I just think he has colds and his sister goes to school. And I think she brings stuff home and all that kind of thing. So when I'm watching him feed, I'm immediately noticing on the bottle and with the straw, like we've got that noisy breathing. And she's, yeah, he's just always noisy. So my first thing is, okay, I'm thinking in my head, I think we maybe have laryngomalacia. And so I talked to her about, I think a referral to an ENT would be good. I'm, a little bit concerned about some of the coughing, some of that noisy breathing, counseling mom on that. And so that's when we got the referral to the ENT, which actually ended up being you. And so he went to the appointment, and in the meantime, we were just working on getting him comfortable with meal times. He's super aversive to everything. What can we do to at least pace him and make it a little bit easier for him? We did start working on the straw and open cup a little more. We focused on the open cup initially because we could at least pace him a little bit more with it. The straw tends to be really fast for some kids. And for some kids too, like it is normal to cough when you first start the straw cup. It's hard to coordinate and hard to figure out. And so part of it was him also being like, what am I doing? I don't know how to do this, but we're coughing on the bottle. We shouldn't be doing that. So he ended up going in, and this was a mom that was very timid. What's going to happen? What are they going to do? What's going to go on? What does this mean? And she asked lots and lots of questions. So I tried to prep her a little bit of, this is what's going to go on. This is what they're going to look at. And it's just really going to tell us like what direction we need to go into. And he ended up getting diagnosed with laryngomalacia. And you had mentioned like it was a more mild form of laryngomalacia, but he had really severe reflux. And we had talked about that, the study that you had mentioned of that is really probably what was more so contributing to him having a little bit of trouble swallowing, because his pharynx was just like the sensation had to be very diminished because he had such severe reflux. And we had started him on omeprazole, I believe it was. And so he started taking that, and it was like within 8 weeks, we were a different kid. We were drinking from the straw and open cup fine. We were done with the bottle. We weren't coughing on any of the things. We were very quickly transitioning to doing chewable solids. And I mentioned this too, because I sometimes find that kids with more severe reflux don't want to eat chewable solids because it impacts and just doesn't feel great. And they just want to drink and swallow things that are super, super easy. And so for him too, I was like, I don't know, there might be reflux too, but the noisy breathing was one of the biggest signs of like, there is something airway going on with this kiddo. And once that was resolved, like I said, I ended up seeing him 8 times after that. And we were on our way and doing really great. And he's just a great case I like to share, because if you don't truly find what that underlying reason for the difficulties are, nothing was going to change. I could have sat there and pushed forever on, okay, come on, let's take more bites of food. Let's practice chewing. Let's drink from the straw. Let's do all these things. And he would have continued to just become more and more averse to meal times.
Absolutely. And I think that also supports you brought up a good point about, and that's what I have to tell families too about reflux medication. So when we start reflux medication, I make sure I tell them like, this is not going to like game change overnight. This is not, you're not going to have an improvement overnight, because in theory, it does take about 4 to 6 weeks to improve your laryngeal sensitivity. So I do tell a lot of families like, hey, you may not see a difference right on, just stick with it. And with that patient, absolutely, they had one of the interesting things that I think Mama brought up. She's like, I just feel like I always want to like clear my throat for him, like after he eats. And I do find that with a lot of families, they'll sort of mention that, it just sounds like there's stuff back there and wet. And I want to clear my throat for them, or I just want to suction their nose, bulb suction their nose, and nothing comes out, and they still sound noisy and wet. I'm like, oh yeah. So to me, and that's not a hard and fast rule. To me, that always goes to, hey, they have decreased laryngeal sensitivity. They have even their own saliva or secretion just sitting back there. And since they can't sense it, they can't go and clear it, or they can't cough and clear it. Yeah. I do feel like another point with that case was that I do see a lot of patients that come in initially that see me that may have not seen a feeding therapist or had any therapy at all. And the referral is for tongue or lip tie. And they absolutely 9 times out of 10 do have what looks like an ankyloglacia. But when we start talking more about it, it's the families sometimes will say, or more, I feel like more often than not, we'll start going towards what's the breathing. They'll say, oh, they breathe horrible. Their latch may be an issue here and there. We may have some difficulty, but honestly, I'm more worried about the breathing. And then we started talking about breathing. I was like, let's figure that out. Oh, you can do that too. We thought we were just here for the tethered tissue.
Yep.
And I was like, no, we need to figure out the swallowing thing. So sometimes that's hard though to bring up that conversation, because I do feel like a lot of families that are referred for that, they've been struggling for a long time. And we had, our oldest did have some colic, and he probably had reflux. He wasn't on reflux medication. My oldest probably had Laryngomalacia, but we didn't do anything about it. Of course, like the saying that the cobbler's children have no shoes. So my son probably had that. For us, we went through some difficulty breastfeeding with my wife, went through some difficulties breastfeeding, and I was there supporting, but it was tough, and he was very colicky. And I feel like at that point, as brand new parents, somebody could have told us, you clip his toenails 3 times a night and that will fix the feeding issue. And I would have done it. I absolutely would have, like, yeah, we're clipping his toenails every night. So I do feel like sometimes when the families are coming in, they're frustrated, they're tired, they have these feeding issues. And to me, I know when they put all their eggs in this basket of, oh, it's just a tongue tie and we get this and we're going to feed and we're going to not snore anymore. It really sometimes is tough to break that. Let's take a step back and let's look at this little person as a whole, and tell me about the breathing, the suck, swallow, breathe. So I do feel like you said, that I remember that family in particular, and there was we talked a lot about the release that they had. And I think that family still went back to it a lot. Maybe we need a revision.
Yeah, that's a big one I'll hear too. Oh, is it that? And I think what we figured out is it may not have ever been that, and that we had these airway things. And I'm a big proponent. If I am even concerned about potentially there is a restriction, and I've gone through all my things that I can think of, and I'm still concerned about it, that I really think an airway consult needs to happen before any major procedure, like before the frenulectomy is done. And I know people talk about it as being a very simple procedure, but it's not. And I think it needs to be thought of a little bit more seriously for children. And oftentimes there was an airway thing that just wasn't completely obvious to us. And, sometimes the airway stuff is pushed onto the tongue tie. I know I've heard of that as well, but a lot of the research shows us that it can actually make obstructive sleep apnea worse, but that's a conversation for another day. So I want to hear about some of your cases though, things that have gone on.
Yeah, I think the case that sort of dovetails on what you were just discussing was a child who was 7 months old, and they referred to me for noisy breathing. And the mom was, I think it was her second child. And she comes in and says, my 8-month-old has noisy breathing. My pediatrician thinks it's floppy airway. And so it came in floppy airway. Okay. And so we were sort of talking about things. And as we get more into it, she was like, wait, told me he's always had it since birth. Like right at birth, we've always had it. Hasn't been a great feeder. Seems to, sometimes we'll cough on feeds, but not always. But I have a 3-year-old also, and she's a single mother, trying to do these things. And so he seems to be gaining weight. But they told me with this floppy airway that he'll outgrow it. So I'm just watching it. There was this event. We had an event, like a choking event, and it just made me worried. So the pediatrician and I both decided to see an ENT. And I was like, okay. So we go through the history, and it turns out when we really focus down on the feeding, and she's like, yeah, it's taking him. We're still in the bottle. We're in a level 2 bottle. I think at that point they were taking. Sorry, I know he was 6 months old. Excuse me. At that point they were starting soft foods, but she was worried because that choking event started with some baby foods. But she was like, with a bottle, he's always taking longer than 45 minutes to take a bottle. And I was like, oh, how much does he take? And she went through, it doesn't matter if it's 1 ounce or 3 ounces, it takes him more than 45 minutes. I'm like, why does that happen? She's like, he seems like he gets choked up and just can't breathe at the same time as feeding. And I was like, oh, that's not normal. So we went into that a little bit more. She also described, hey, he snores horribly at night. And as he's gotten older, it's gotten worse. And so that's the other thing, as something that I look at in my history, is I am a huge fan of mother's intuition. So moms know what's right. Yeah. When moms say, this is getting worse and this terrifies me, that terrifies me that they're saying that. So we need to look into that. So if that mom said something's wrong, I feel like we're missing something. As we're getting older, things are getting worse, feeding and breathing. We perform flexible laryngoscopy. And with everything she was describing, I was expecting to see a severe laryngomalacia in my mind. I'm like preparing to give this discussion of how the patient needs surgery. We may need to skip these tests and just go right to surgery. And he had very mild laryngomalacia, which was really interesting. So to me, I was like, this doesn't make sense. So we talked about it. We reviewed the images. First and foremost, like, we need to figure out his feeding, and why don't we get a sleep study too at the same time? And he definitely was somebody that worried me. So we actually had a video swallow study because he had been born full term, hadn't had any radiation or any issue or any imaging studies prior to that. And his video swallow study, he was safe on honey consistency. He aspirated everything, and just everything that you could picture that was wrong with a swallow study he had the sleep study like shortly thereafter, and actually had like moderate to severe laryngomalacia, or excuse me, moderate to severe obstructive sleep apnea. So to me, I was like, why? This doesn't make any sense. Like, what's going on with this child? So after discussion with mom, and these things happen pretty quickly, I was like, I think the next step is we've already had him on reflux medication. We need to evaluate his airway, because to me, we have a child that has a very severe sleep apnea score. He's aspirating everything. We can't really sustain our hydration, our caloric intake with honey consistency. He's only 6 months old. So we decided to go to the operating room, and we said, I told them we possibly would do a supraglotoplasty, but we really just need to figure out like what's going on. Mm-hmm. And he was, at that point, I think he was like close to 7 months. We did his laryngoscopy, and usually when we do our laryngoscopy, we have our laryngoscope set up, we have all our instruments, we're measuring things. And so we have this instrument called a right angle probe. So it measures the height of the interretinoid space. And so the interretinoid notch, or the posterior larynx, has some cartilages and an interretinoid space that separates the opening of your esophagus to the opening of your airway. And this right angle probe tells me, okay, how high is this wall? And so I'm resting it there, and it just sinks, and it sinks. And all of a sudden, I'm down to third tracheal ring. So this child had mild laryngomalacia and had a type 3 laryngeal cleft. So this actually had gone all the way down to he didn't have his cricoid cartilage posteriorly was absent. So it went down to his first tracheal ring. And it wasn't that his laryngomalacia was contributing to his obstructive sleep apnea. It was the redundant esophageal mucosa that was spilling into his airway posteriorly. That changed everything, honestly. And interestingly, in this whole workup, he had seen a lactation consultant and did have, happened to have a tongue tie at the same time. But really, his work of breathing, his feeding was due to this pretty significant type 3 laryngeal cleft. That, to me, drove home this point of, again, always listen to mom. If we have progression of symptoms and things that support obstructive sleep apnea or even laryngomalacia, it's important to assess everything to make sure it's not a synchronous airway lesion, and that's contributing to all these symptoms as well. And that it really, to think about the airway and even, again, the child as a whole. So that child ended up seeing, after that, we sort of diagnosed that child unfortunately needed a G-tube to let his larynx heal a little bit. He had some laryngeal rest because his airway, he had been aspirating for 6 months, and his lower airway was pretty rough looking. So we had to get him a little bit older and healthier before we finally repaired him. But it's one of those things that not everything that is stridor is laryngomalacia. There's so many things that can contribute to that.
Mm-hmm. Yeah. And I think that's why I will push for those like airway consults before, when I'm thinking about like tongue tie or even laryngomalacia. It's okay, let's still listen to all the signs and symptoms. Let's still listen to what's going on. And you can try some of those less invasive things, but if things are getting worse, especially like you said, if a parent tells me something's getting worse, huge red flag that we need to figure out what's going on, because they're with the child all the time. They'll know. They will know.
Right. So, absolutely right.
Super interesting though. And like you said, it is probably the most common cause of, or most common reason for stridor, but it's not the only one, looking at all of those other options as well.
Yeah, absolutely.
Awesome. Any other cases to share?
Let me think. Yeah, one more. So there was a child that was referred for again, noisy breathing. Same thing. Moms are always, so the mom said, been a noisy breather since birth. Feeding, again, takes longer than 30 minutes to bottle feed. And what was interesting about this child is he had pretty significant retrognathia. So his jaw was set back significantly as well. So we ended up scoping him. He had moderate laryngomalacia. We started him on reflux medication. He did have pretty extensive laryngeal edema as well. So even after initiation of reflux treatment, we feezed him to do his swallow eval. He was still pretty swollen, but his sleep apnea score was very significant. It was about 3 times what it should be. So we, after discussion of things, when I actually talked with our GI colleagues, the decision was, well, we'll have to go to the operating room. And so we did his supraglotoplasty, and he had a pretty uneventful course, other than His swallowing was a little bit tenuous, so we had to thicken him to half nectar a little bit more, but he still had this jaw. So his surgery was overall difficult. And that when your jaws were more retrognathic, it allows you decreased visualization of the larynx in order to do all these things. But even through his surgery and everything, he always remained like really swollen. And we ended up getting, mom was overall happy. He's doing better. He's taking less time to feed. He's still really noisy. And so we waited about 1 or 2 months. He was on reflux medication. We got another sleep study, and his sleep apnea was like, it had fixed it by 5%. So his sleep apnea was still really severe. And so at that point, we were again looking at, why is his larynx, still red and swollen? His jaw definitely plays a role with sleep apnea and invasive tongue retraction. This is not a child I'd recommend any type of tongue tie release on, even if you had one, because of his basic tongue. But what ended up happening is we got GI more involved in the impedance probe, and we found he had a milk protein allergy, and it caused his larynx, his supraglottis, his trachea, everything was just really inflamed. So once they targeted therapy to that, we did another sleep study, and his sleep study numbers came down to almost normal, even in the setting of this very small jaw. Another child that it's not just the larynx. There's definitely other things that can affect your airway, especially in a little one. And it's sometimes important to load the boat if we're not having that normal post-op course with improved breathing and improved symptoms afterwards.
Yeah, absolutely.
It's in the family.
Yeah. And I think that's just a testament to if there are concerns with airway, just getting that evaluation, because if you don't get that initial referral to look at it and, laryngomalacia is mild, why do we have such severe symptoms? Mm-hmm. Then to look further. And so just making that initial referral so that you can even just start the journey of figuring out what's going on, because breathing is obviously important for everything, but from a feeding therapist, breathing trumps all. And if I do not have a child that their airway is compromised in any way, I'm going to have a lot of trouble in all levels, but especially in those infants. But I'll even see it in some of my older kids too, where it's just so compromised, they have to work that much harder to be able to achieve the tasks that we're trying to do. Just like you talked about with drinking from the straw or something, it can just be a lot harder. So they don't want to do it. So yeah, I appreciate you so much for talking through this. And it was just so beneficial. I continued to learn from you all the time. So I appreciate you sharing your knowledge and your expertise and your experiences with everyone. And yeah, we'll have to do this again sometime.
Absolutely. Thank you. Thank you so much for having me. Really appreciate it. So I appreciate what you do for our patients as well. Thank you.
Thanks. Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow me, on Instagram at Pediatric Feeding SLP, or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.